Good morning, everyone, and thank you for joining us for our third annual virtual Best of Breast. This is a case on combating endocrine resistance. My name is Dr. Reshma Mahtani. I'm a breast medical oncologist at the Sylvester Cancer Center, University of Miami. I'm pleased this morning to be joined by colleagues. I'll ask you to introduce yourselves. Elisa?
Hi, I'm Elisa Krill-Jackson. I'm a breast medical oncologist at University of Miami Sylvester Comprehensive Cancer Center as well.
Lisa?
Hi, I'm Lisa Hineman. I'm an oncology nurse practitioner and director of clinical operations at Los Angeles Cancer Network in downtown Los Angeles.
Kelly?
Hi, I'm Kelly Hunt, and I'm a breast surgical oncologist at the MD Anderson Cancer Center in Houston, Texas.
And last but not least, Mike.
I'm Mike Cusnir. I'm the medical director at Mount Sinai Medical Center in Miami. I have an interest mostly on gastrointestinal oncology, but also a lot of interest in integrative medicine and oncology.
Great. Thank you all for joining us this morning. We'll be discussing in a case-based format a patient that has ER positive, HER2 negative breast cancer. And we'll go through treatment options, local treatment options and systemic options through the early stage and metastatic setting. So with that, let's jump right into our case. This is a 40-year-old premenopausal woman who palpates a mass in her right breast, which is about 2.5 centimeters on imaging with suspicious axillary lymph nodes. Both the breast lesion and the axillary node are biopsied and confirm invasive ductal carcinoma, grade 3, ER 90%, PR 5%, HER2 negative. She has a past medical history of anxiety and depression and a family history of breast cancer and pancreatic cancer. She's divorced, has 2 young children, and is working full-time as a teacher. She is very pointed in letting you know at her initial consult that she is interested in holistic treatments, integrative treatment options, and takes multiple supplements. The decision is made to take this patient to surgery up front, and she undergoes a lumpectomy and axillary lymph node dissection where she has a pathologic T2 tumor with 6 nodes involved with tumor, and the markers are the same. She's treated in the adjuvant setting with anthracycline and taxane-based chemotherapy, radiation, and aromatase inhibitor and ovarian function suppression. The therapy in general is very poorly tolerated. She reports hot flashes, mood issues, arthralgias. I think this is something that many of us see in practice every day where patients are having tolerability issues to systemic or endocrine therapy. After 1 year, she actually has to discontinue the treatment due to side effects, and she's offered tamoxifen to complete the 5 years. At this point, at the 5-year mark, she regains menses and is 45 at the time that she completes the 5 years. She is offered extended adjuvant endocrine therapy, and she declines this as she didn't tolerate the initial 5 years very well. So we have many parts of this case that we can dive into in terms of decision making. And of course, the first would be the decision to take her to the OR up front as opposed to offering neoadjuvant therapy for this ER positive, HER2 negative, node positive patient. Also, in terms of systemic treatment options, the choice of endocrine therapy, and now with newer data that we have with at least one CDK4/6 inhibitor, abemaciclib, in the adjuvant setting showing a benefit, it'll be an interesting discussion to see how we would approach that treatment option. Specifically, the endocrine therapy decision-making with regards to toxicity management is something that comes up quite a bit, as I mentioned, and we'll talk about some strategies to handle side effect management of hormonal therapy, and also bring Mike into the discussion in terms of supplements and other integrative medicine approaches. So with that, let's tackle the first question, and I will turn it over to Dr. Hunt to take us through the surgical decision-making.
Great. So in a young patient like this who has node-positive disease at diagnosis, there are many questions that we want to address with her in terms of deciding about surgical treatment options. And certainly systemic therapy is going to be a big part of her treatment. So the question is whether she should have the systemic therapy first or go to surgery first. So we know that preoperative systemic therapy, also called induction systemic therapy or neoadjuvant therapy, can increase the incidence of patients that are able to have breast conserving surgery successfully. And this is true from many studies that have shown the downsizing that occurs in the breast. And we don't know from this case the breast size to tumor size ratio, but she was able to undergo upfront surgery. So presumably for a 2.5 centimeter mass, she had a favorable breast size to accommodate that surgery. But sometimes that is a consideration in terms of patients who might have a smaller breast size to tumor size ratio, and that might be a consideration. We know that the systemic therapy also decreases the incidence of positive nodes at the time of surgery. And this is true in both patients that are clinically node negative at presentation and those that are clinically node positive. And we also know that long-term outcome correlates with pathologic tumor response rates. So those are several reasons why we might want to consider neoadjuvant therapy in this patient. Also the fact that she's young and we might need to consider genetic testing for her. This neoadjuvant therapy gives you time to complete that and for her to consider her surgical options in terms of breast conserving surgery versus mastectomy. Next slide. So we know that from many studies, including these from the NSABP B18 and B27, where they compared adjuvant versus neoadjuvant systemic therapy in patients with operable breast cancer, we know that both overall survival and disease-free survival were equivalent whether patients received their therapy before surgery or after surgery. Next slide. But again, we do get information from the patient's response to therapy that can be very useful in terms of prognosis. And this is data from Fraser Simmons, who's a pathologist at my institution that developed the Residual Cancer Burden Index. And what this does is evaluates the tumor bed in the patient after chemotherapy at the time of surgery, and then also the nodal status, both the number of nodes and in the axilla, and evaluates the residual burden and classifies it as RCB 1, 2, or 3. Of course, a pathologic complete response is no evidence of tumor in the breast or the regional nodes at the time of surgery. And you can see from this that relapse-free survival correlates with the residual cancer burden index. And so pathologic complete response in the blue line and RCB1 in the yellow line are quite similar, minimal residual disease versus pathologic complete response. Those with RCB2 or higher volume disease such as RCB3, like the patient in our case, have a much worse prognosis. Next slide. We also know from many of our current studies that tumor biology correlates with the rate of breast conserving surgery and pathologic complete response to neoadjuvant systemic therapy. So most of the earlier studies, like the NSABP studies that I showed you, incorporated all comers with all different biologic subtypes. And we know now from more current data that we are going to right size the systemic therapy based on the biologic subtype. Next slide. So from the ACOSOG Z1071 trial, which included patients with all different biologic subtypes, we see that patients that had triple negative breast cancer were more likely to have breast conserving surgery. Also, those with HER2 positive disease were more likely to have breast conserving surgery, whereas those with hormone receptor positive breast cancer were more likely to have mastectomy, as we don't see as much downstaging with standard neoadjuvant systemic therapy regimens in those patients with hormone receptor positive disease. Next slide. Now, one other approach that has been utilized is to look at neoadjuvant endocrine therapy for patients with strongly estrogen receptor positive disease. Now, this is a study from ACOSOG looking at patients in postmenopausal patients with ALRED 6 to 8, clinical stage 2 to 3, hormone receptor positive breast cancer randomized to one of 3 aromatase inhibitors. So that would not fit our current patient who's premenopausal, but in this study, a key finding was that over 50% of patients that were thought to require mastectomy at baseline were able to undergo breast-conserving surgery. And there was no significant difference between the 3 AIs with this approach. So this may be something to consider for our postmenopausal patients. Instead of using neoadjuvant chemotherapy, perhaps neoadjuvant endocrine therapy is an approach that we might utilize. Next slide. The other piece that we've learned from the ACOSOG Z1071 trial is that pathologic complete response rates in the axilla mirror that to what we see in the breast. So in the Z1071 trial, all patients had node positive disease confirmed by biopsy before systemic chemotherapy. And what we can see here is that similar to what we see in the breast, those with triple negative breast cancer were more likely to have pathologic complete response in the axilla. Those with HER2 positive, almost 65%, had no positive nodes remaining in the axilla, but it was the hormone receptor positive subtype that continued to have a large burden of disease in the axilla with standard neoadjuvant systemic therapy regimens.
Sorry, I didn't mean to cut you off there. So
Thanks.
Kelly, I'll ask you, you brought up this issue of response rates based on subtypes, and there are various assays, including Blueprint, PAM50, these molecular assays. I'm curious as to whether you see any value at present in utilizing that information to make decisions regarding neoadjuvant treatment, especially in an ER positive patient, HER2 negative, where we know, as you mentioned, that PCR rates are lower, but perhaps higher in a luminal B as compared to a luminal A patient. Are you utilizing that information, or do you think it's not ready for prime time, so to speak?
So that's an excellent point. I think many people are using that approach. At my institution, we're not typically doing that for younger patients with node positive disease, but I think based on a lot of recent data that has come out with different tools such as Oncotype and others, that yeah, we can certainly use that information up front on the core biopsy to try to determine which patients may benefit from chemotherapy in the neoadjuvant setting. So yeah, I think that's a good approach to consider.
Mm-hmm. So as we move through this case and discuss the other aspects of decision making, before we move on to the endocrine therapy decisions and the use of an adjuvant CDK4/6 inhibitor, I'm going to turn it over to Mike for a couple slides just to talk to us about the use of integrative medicine approaches, especially in patients that are interested in utilizing these therapies during adjuvant therapy. And is it helpful? Is it harmful?
Yeah, so the interesting thing here is that there's a lot of data that has been published, and the ASCO, the American Society of Clinical Oncology, has endorsed the Society of Integrative Oncology Clinical Practice Guidelines. And as you can see, this is just like the front page of that article from 2018. It hasn't been updated, but it's expected to be updated by next year. There's a lot of therapies that are of low risk and that definitely could be integrated without much of an issue, like music therapy, meditation, stress management, yoga, anxiety and stress reduction. The thing that you can see on this slide that it's missing here, it's for a lot of the different supplements. And as you can see, kind of like on the third to last line, they even make a note of acetyl L-carnitine as not recommended for peripheral neuropathy, and a lot of our adjuvant patients are getting treatments that could give peripheral neuropathy. And part of the reason that is not recommended is that there's a concern that there could be some interaction with curative intent treatments. So if you can move to the next slide. The second thing is also on nutrition. So we're gonna talk a little bit more on supplements, and I'm always overly concerned when you're talking about supplements that patients confuse supplements with nutritional supplements. So if somebody tells me, is it worthwhile to have a healthy diet while I'm undergoing treatment? The answer is always yes. And a healthy diet is of many different levels. So one thing is that, and you can see on the top uh, corner there, alcohol. We have made a point, and the American Society of Clinical Oncology have said it, that there is no safe dose of alcohol at any point. That there's risk of increased breast cancer on patients that are at risk, and even survival differences. It was reported not even 2 months ago that on patients that consume a single drink per week may have a decrease in survival. So I always make a point. Nowadays we live in a society that alcohol has become a social issue, and a lot of patients will do it. But then on that circle on the other side where it says cruciferous vegetables, um, if the patient tells me that they want to eat more cruciferous vegetables and have a low glycemic diet, a Mediterranean diet, it's always healthy. If they tell me that they could supplement a bad diet by eating supplements as part of that compensation, it's not good. There's studies that have been shown, and I think that there's a slide later on of the risk of using supplements, and even things like vitamin B12 supplementation and all that could even be harmful. We know this on many different cancers. This doesn't go only for breast cancer. We had the SELECT study on prostate cancer that was shown to be harmful of doses of selenium as supplementation. We have the CARET study in lung cancer, and the list goes on and on. I always say that the most important is actually a healthy diet, and that's part of what we kind of like have seen on the epigenetics, on the expression of genes. And on the lower part of the slide you could see how two identical twins at the age of 3 years old have very similar type of like genomic expression on, just an example, on chromosome 17. But as they age and they probably behave a little bit different in their life, their chromosome 17 could be quite different. So that's quite important.
Thanks, Mike. Does anybody else want to weigh in here about how you're handling these questions? Patients are very interested, and whether they're telling us or not, they're taking various supplements. Are there any resources that anyone is consistently using that they know of to be reliable, or any other counseling that they're giving their patients that you want to share with us?
This is Lisa. I find that with my patients in California, you can imagine we have a lot of people who, there's a million different supplements, and CBD is a big thing down here. But one of the things I tell them is that when you look at all the supplements, it's kind of like our very congested 405 freeway here. The more you put in there, the slower the traffic's going to go. So you might get toxicities from medications, or something might go through too fast. You don't want to do anything extra that's going to interfere with what you're trying to accomplish with your endocrine therapy, as well as the fact that I completely agree with Dr. Cusnir that by getting them to eat a good diet, you don't need a lot of supplementations if you're getting it in your nutrition, and that's the best way to get it anyway.
Mm-hmm.
If I can make a quick parenthesis regarding CBD, that it's also coming quite a bit into my practice, and it's not on this case because this is a hormone receptor positive case, but on the triple negative cases, that don't forget CBD receptors are also in the immune system. There's data from the Israeli group that has shown that on patients that are on immunotherapy, CBD could be harmful in interacting with immunotherapy. So I put that as a parenthesis, even though that is not on this case specifically.
Okay, thank you. So let's move on to the endocrine decision making here. So in terms of hormonal therapy choice in this patient who's premenopausal, We have the option of tamoxifen alone or in combination with ovarian suppression or an AI and ovarian suppression. And I'll say that we know that the addition of ovarian function suppression or ablation to either an aromatase inhibitor or tamoxifen for some patients results in a clinically meaningful reduction in the risk of recurrence. But as I'll go through with you now, it does increase toxicity. The approach to ovarian function suppression in premenopausal women is informed largely in part by 2 large phase 3 studies of premenopausal patients with operable hormone receptor positive breast cancer in which chemotherapy use was optional. So in the SOFT trial, over 3,000 such women were randomly assigned to one of 3 arms: tamoxifen alone, tamoxifen plus ovarian suppression, or exemestane plus ovarian suppression. And women were allowed to enter following surgery, in which case, surgery alone, in which case they were randomized within 12 weeks of surgery or within the 8-month time period at the end of chemotherapy, provided that they had biochemical proof that they remained premenopausal. Stratification factors are shown on the left of the slide, and about 30% of patients were node positive. I should mention that the initial statistical plan involved a pairwise comparison between the 3 arms. However, there were fewer anticipated disease-free events observed, and the statistical plan was therefore changed to make the primary comparison in the SOFT trial to be tamoxifen versus tamoxifen plus OFS. And the secondary endpoint was the comparison. The secondary comparison was exemestane plus ovarian suppression versus tamoxifen alone. The comparison of the 2 ovarian suppression arms were handled by a combination of those arms in the TEXT trial as well. So in the overall population, you see here the SOFT disease-free survival with 8-year median follow-up. Compared with tamoxifen alone, tamoxifen plus OFS improved 8-year disease-free survival rates, 83% versus 79%, as did exemestane plus ovarian function suppression, 86% versus 79%. And with longer 8-year follow-up, the SOFT trial is now positive for its primary endpoint. The benefit was about a 4% difference when looking at tamoxifen, with the addition of OFS, with a greater benefit, 7%, looking at the use of exemestane. As we look at this 8-year median follow-up, disease-free survival, looking at various different groups, looking separately at the cohorts of women who had not received prior chemotherapy, there's a more, the absolute benefit, of course, was more in the patients that had prior chemo, as they were at a greater risk for recurrence. And outcomes were further improved for the use of exemestane plus ovarian suppression, where the absolute benefit was 9%. And what really stood out to me in these data, we're looking at these very young patients, less than 35. They tend to have aggressive tumors and are at particularly high risk for recurrence. The combination of exemestane and ovarian function suppression to tamoxifen showed a 14% absolute benefit, and looking at how these patients did on tamoxifen alone with an 8-year DFS of 64.3% is, of course, very disappointing to see. However, if you look at freedom from distant recurrence at 8 years, it was similar between patients receiving tamoxifen plus OFS versus tamoxifen alone, 89% versus 88%. And there was only a modest improvement for those receiving exemestane plus OFS. As expected, looking at adverse events, there were differences seen starting at the bottom of the slide. As we know, the side effect of aromatase inhibitors in terms of decreasing bone density, there were a greater percentage of patients that had osteoporosis. Musculoskeletal symptoms were a bit higher in the exemestane group. And then you see differences with regards to endometrial cancer and thromboembolism being higher, as to be expected in the tamoxifen group. So the importance of longer follow-up with this 8-year follow-up is that the benefits of OFS are now emerging even in lower risk patients, and there's an emergence of a survival signal, but the absolute benefits are still higher in those with higher risk disease. So we have to carefully choose who we are going to offer ovarian function suppression as we try to balance the benefit that we get with the risk of recurrence and the side effects as we follow these patients for longer. And in terms of side effects, that's a nice segue to turn it over to you, Lisa, to talk about how you're managing some of these side effects and what we usually see.
Thank you. One of the most important things I find is to have a really good baseline conversation with these people right up front about what you're looking at. I have a large group of women under the age of 40 that are often neoadjuvant hormone positive breast cancer, and many of them have partners, married, or even single, that in this time where we've had the pandemic, I usually would have people in the room with them, their significant other. Sometimes now we've had to do it on the phone, but really important to talk to them up front about this, because when someone is, perimenopausal, menopausal, they have gone slowly over sometimes years to get to that point. In the younger women, all of a sudden it's like turning the lights off, and they can have a lot of symptoms at once. So I had the conversation starting with what they're going to do for the total therapy, whether it's neoadjuvant chemotherapy, surgery, radiation therapy, endocrine therapy, to say that this is a journey towards a good long-term outcome. And that, there's a tendency historically to say, oh, we get through the chemo good and everything else is optional. But particularly when we're dealing with hormone positive breast cancer, letting them know that oftentimes one of the most significant parts of their therapy after the primary part is going to be the endocrine therapy, and what we need to do. That they may have some vaginal symptoms associated with it. And that's very important up front, to have those conversations and be comfortable ourselves to have those conversations up front, because otherwise for a lot of women, it's very embarrassing to even bring up the fact that they might have vaginal dryness or pain with intercourse, or the fact that because of the dryness, they might have more urinary tract infections, and discussing the things that we can recommend: Replens for just vaginal lubrication, drinking more water. And especially now when a lot of people have been wearing masks a lot more, the hydration level has gone down, telling them to make a concerted effort to drink more fluids, as well as the fact that to be sure that, for intercourse, different things from foreplay to adding in a soluble lubricant before and during intercourse, and just helping with that. Musculoskeletal symptoms are something we see a lot of. One of the things that's come up a lot more in a few of the studies is the fact that they've seen that people who have previously had taxanes and growth factors can be more predisposed to having these arthralgias associated with some of the aromatase inhibitors. And it's really led us to look at particularly the growth factors that we're using in the taxane portion, depending on which protocols we're giving, to see, can we minimize these in any way to look ahead at the future for being able to go with the aromatase inhibitors with this as well. And it was put out initially that there were some of these arthralgias when aromatase inhibitors first came out, but they didn't talk about it as much. And it was usually our patients. We learned so much from our patients and what we're talking about. Even with the trigger finger, which is something we can see, there can be a compression of the tendons in there that sometimes even require surgery, not frequently, but they've done that. And we tend to see this a little bit more with letrozole and exemestane than we would with anastrozole per se, and even some carpal tunnel syndrome. And then as far as the vasomotor symptoms or the hot flashes, that can come on as well. When some of them have had chemotherapy up front, they've started to have some of this as the ovarian suppression naturally from the chemotherapy. But again, particularly in some of the younger women, they end up having it quite significantly that they notice it. And something as simple as telling them about layering their clothing, because you were used to wearing the same outfits that you would, and all of a sudden your temperature goes up to 105 degrees and then drops back down again. Doing that, as well as, again, the hydration, diet, limiting the sugar in it, just balanced nutrition in general. Next slide, please. And then, right up front, one of the things is the biggest complaint when we did studies to look at, we thought, oh, pain was terrible, nausea, everything else. When they took all those factors out and improved with symptom management, we saw that the fatigue was still so significant. So by getting them right off the bat to be doing some exercise, even just walking, training, this can help with both maintaining weight as well as strength and the flexibility that can contribute the lack of flexibility and causing arthralgias and whatnot. They have seen some improvements with omega-3 fatty acids to improve joint pain in obese patients, which is over 30 BMI. But on the other hand, they show that with the aromatase inhibitors, some people who actually have a little bit higher of a BMI might have less from that standpoint. I still think it's better to limit that BMI because of the estrogen storage, but that is there. Acupuncture we have found to be something very helpful for some of these people. They, in looking at the studies of looking at, sham or something that acts like acupuncture but isn't as the placebo effect, they actually did show that there was some benefit in the acupuncture. And one of the other things that we can see is in duloxetine. Sometimes when shutting these hormones down right away, it can not only be that feeling of the estrogen has kind of dulled that sense of pain. When the estrogen is completely suppressed, there's a lot more feeling of that discomfort, if you were, because of the nociceptor involvement. And they have seen that things like duloxetine not only can help by improving the mood, but there can be some decrease in the vasomotor symptoms or hot flashes, and even with the arthralgias from that standpoint, as well as gabapentin is something that we've used for a long time intermittently. The key thing is knowing the patient and knowing what they're into. You can have the best recommendations in the world, but if the patient doesn't buy into them or agree with them or see where it might benefit, as well as ask the patients, what have you been doing? What have you found works better for you? Even with vitamin D therapy, as we know that there can be bone loss associated with aromatase inhibitors, some people have really found benefit in their mood from vitamin D, as well as uptake of calcium for the bones. And others have said that they didn't see much at all. And then lastly, one of the things that we could do is switch therapy. Again, we have to know the baseline. Did they maybe have some rheumatoid factors up front? Are they sedentary? Activity can make them be a little bit better. We've done everything we can. We've started with this aromatase inhibitor. They're really complaining because about 10% will have very debilitating symptoms from them. We'll say, well, let's just go ahead and give it a break of 3 to 4 weeks and reassess. Has it changed? Has it not? In some instances, it has changed dramatically. Others, it hasn't changed at all. If we can't go back to that same medication, we might go ahead and change it to something different.
Thanks, Lisa. Mike, from your perspective, are there data that you can share with us in terms of integrative medicine approaches that might help manage some of these side effects?
Yeah, so exactly as Lisa was saying, the acupuncture, which is going to be in a second also shown to be beneficial, but then some of those side effects, and again, there's been countless studies done with black cohosh. There's different things that have been tried, not great results from most of them, and then there's even the risk of antioxidants, as I mentioned earlier, and things as little as vitamin B12. And you can see here on these curves that the never takers actually do better than the ones that take it. And again, not dramatic statistical changes, but it is something to be still of concern. So the different supplements are quite difficult. Now, it's very different when we're treating a symptom and we're treating something specifically, like precisely the dyspareunia that was mentioned by Lisa and things like that. That when the patients just take irrationally a lot of supplements without a good reason. So I usually reserve the supplements to treat symptoms, but I'm very careful on patients that are being treated with a curative intent. If the patient is treated on a palliative setting is different. Now, the acupuncture that I mentioned, you could see for all the different side effects, and you can see that the forest plots here are not great, except for hot flashes, which is the one on the top left level. Most of the other ones have not shown to be, and this meta-analysis has been updated twice. This is the meta-analysis that has been looked into all the different studies and just adding them together. This is the 2020 version that was updated, and hot flashes, they do help. Fatigue, it also improves, and then a little bit on the gastrointestinal symptoms. The other ones are not great, but it's something that I use quite a bit in my practice.
Thanks. So for the first time, we now have an additional option, although not approved in this setting, but with these data, there is a consideration to have this discussion, if authorized by insurance, regarding the use of adjuvant abemaciclib in very high-risk patients. And I'll ask you, Elisa, to go through these data with us. Oh, I think you're on mute.
Yes, that was 2020's phrase, but it isn't stopping in 2021, huh? So the Monarch-E trial was recently presented at our major meetings of adjuvant abemaciclib plus standard endocrine therapy in patients with hormone-sensitive breast cancer. Now, what to know about this trial was the first adjuvant a CDK4/6 trial to show positive results. There are still trials ongoing, but this trial used a very high-risk group of patients. So the patients had either 4 positive or more axillary nodes. If they had 1 to 3 positive nodes, they had to have at least one of the following things. They had to have a tumor size greater than 5 centimeters, or grade 3 tumor, or a Ki-67 greater than 20%. So this was a really very, very high risk group of patients. The trial was powered at 85% for looking at invasive disease-free survival. Next slide. So what you can see here is the invasive disease-free survival was significantly better. It was 3.5% better at 24 months, which is actually quite a big deal because that's very early separation of the curves. And I think what's important to note is that this is almost all distant relapse-free survival. So when we look at other endocrine therapies, we often see improvements in disease-free survival, and much of that can be contralateral breast cancers. And while we do want to prevent contralateral breast cancers, that's not where our mortality comes from. So we're actually seeing a 3.5% early distant relapse-free survival, which is very impressive. However, the patients on this trial took 2 years of abemaciclib, so I'm not at all convinced yet that this should be standard of care, because perhaps this is just delaying the recurrences and it will not end up in a survival benefit. But I think for our very high-risk patients, this is something that we can consider. So the distant recurrence improvement was seen mostly in bone and liver metastases, really wasn't seen in lung and brain metastases. Next slide. And the safety is what you would expect. So a lot of diarrhea, a lot of neutropenia, fatigue, leukopenia, just what we expect with Verzenio. So again, I think in the future, when we're thinking about adding this drug to our very high-risk patients, we need to have our eyes wide open that this very well may affect their quality of life going forward.
So Lisa, I'm going to put you on the spot here with this patient. If she came to you in clinic, is this the high-risk patient you would consider? She's young, grade 3, 6 positive nodes.
She is somebody I would discuss this with. Absolutely.
I think I share your concerns about not knowing if those curves are going to come together with longer follow-up. But at this point in a young patient who fit these criteria, I've been having the discussion, again, with the caveat regarding insurance coverage, given that it's not authorized or approved, rather, in the setting as yet.
I think it'll be interesting to see the 3-year update and whether the curves continue separation when patients have been off the 2 years of abemaciclib.
Mm-hmm. So let's get back to our case. I've highlighted in purple here the part that we're at in terms of her management. So now she's gone through her early treatment with surgery, adjuvant chemo, radiation, the 5 years of endocrine therapy. And after being off tamoxifen for 2 years, she's still premenopausal at this point. She has a palpable mass in the same breast, and the biopsy again is confirming the same markers. And her bone scan and PET scan also confirm an isolated bone metastasis, which is also biopsy proven. Kelly, I'll ask you to take us through these really important data. This situation doesn't come up too often, but on occasion we do have a patient that has metastatic disease and has an intact breast mass, and this discussion about the value, especially in a patient like this who has a very low burden of distant metastasis, is something that we've struggled with over the years. So I'll ask you to go through these data for us.
Yeah, thanks. So this is the ECOG 2108 trial that was presented at ASCO by Seema Khan and her colleagues in 2020. So the background for this trial is that we do see about 6% of patients that present with stage 4 breast cancer with an intact primary tumor. So a little bit different from our case, where the patient had already had local therapy and developed metastatic disease later with a local regional recurrence. But many of the studies were done by single institutions or using large databases and showed that local regional treatment for the intact primary tumor improved survival. So these were retrospective studies, and as you can see from the slide here, most of them were biased in terms of patients were younger, they had smaller tumors, they more often had ER positive disease, and they had a lower metastatic burden overall. Next slide. So there's also been a couple of randomized trials, and these are data from the Tata Memorial Hospital on the left and then the Turkish trial on the right that looked at randomizing patients to local therapy versus only performing local therapy on progression. And what you can see is that in the Tata Memorial Hospital trial, there was no survival advantage for early local regional therapy, whereas in the Turkish trial, it did favor patients having early local regional therapy with an overall survival improvement in those undergoing local regional treatment. So ECOG E2108 opened in 2011. The last patient was enrolled in 2015. And this trial looked at patients who were registered, again, de novo stage 4 breast cancer with an intact primary. They were receiving optimal systemic therapy based on patient and disease features. And if there was no progression of distant disease 4 to 8 months after receiving therapy, they were randomized to continue systemic therapy alone versus undergoing early local regional therapy. And this local regional therapy included complete tumor resection with negative margins. And for those patients that where it was appropriate, they were to also receive radiotherapy after surgery. So there were 368 patients enrolled, and these are the characteristics shown here. You can see they were pretty similar between the arms, and there were more patients that were postmenopausal. And then you can also see the subtypes listed here, and the trial was not powered to look at the different subtypes overall. Next slide. Overall survival was not different. You can see here based on the log rank test, median follow-up time was 53 months, median survival was 54 months, and there was no difference between early local therapy versus continued systemic therapy between the two groups. Next slide. If we look at progression-free survival, there were 89 patients on each arm that progressed during the follow-up time, and so there was no difference in progression-free survival. Next slide. Now, looking at subtypes, again, these are small numbers of patients, but what you can see is that looking at HER2 positive and then the hormone receptor positive, there was no difference in progression-free or overall survival. If you look at the triple negative cohort, which was a small number of patients, survival was worse in those who had early local therapy. Next slide.
So recognizing that these data don't really apply to our patient as she didn't have de novo metastatic disease, in the situation that you might be referred this patient to consider local therapy, what would your response be?
Yeah, that's a great question, and something that we discuss in our, tumor boards and conferences all the time. And I think it's really an individualized decision these days. Our patient in the case that we're discussing has, I think, what most would consider oligometastatic disease, and there are ongoing studies looking at treatment of oligometastatic disease. And so I think that, she needs systemic therapy as her primary treatment, and then consolidating local regional therapy may be appropriate in the future depending on her systemic therapy and response to systemic therapy.
Agreed. So as we talk about how to approach this patient from a systemic standpoint, I think the first point to make is with regards to the importance of biopsy per guidelines, and then we'll discuss the options. I think many of us now are routinely incorporating CDK4/6 inhibitors into our first-line treatment option, except for the occasional patient who may have compliance issues or some other comorbidity where you're worried that they may not be able to tolerate the treatment. Elisa, do you want to go through these couple slides on the guidelines for us?
Sure. I think it's really important, and the NCCN guidelines recommend that we biopsy all recurrences. So clearly we need staging studies on this patient, which can either be CAT scan and bone scan or a PET scan. I like PET scan to look for lytic bone lesions, especially in this ER positive subgroup. But we do need biopsies, and I think a biopsy of a metastatic site is necessary. What we do know is that patients have a significant chance that their markers and receptors may be somewhat different from the primary to the metastatic site. So it's important to biopsy a patient at first sign of recurrence, and then to check again the ER, PR, HER2 to make sure that we know what we're dealing with so we can give the most appropriate therapy to the person. We also, guidelines suggest that we should do genetic testing on all of our metastatic patients, even if they didn't fit the early criteria for genetic testing when they had early stage breast cancer, because of course we have treatments available now for metastatic patients with BRCA associated cancers. I also think it's important that we do genomic testing on the tumor so that we can look for PIK3CA mutations, ESR1 mutations in patients who have had therapy with an aromatase inhibitor, or any other mutation that might allow us to target therapy for that patient.
So are you sending off for that sort of testing up front? Are you sending NGS testing, especially with regards to the PIK3CA mutation, or are you waiting until the person develops progression on first-line therapy?
I actually, in patients who have relapsed after endocrine therapy, especially after an AI therapy, I am sending genomic testing on that first biopsy or a liquid biopsy when they relapse, because I do want to see if they have an ESR1 mutation. Because when you're thinking about therapy down the line, longer line therapy, you want to know if you can give a steroidal aromatase inhibitor, perhaps after the non-steroidal aromatase inhibitor. I also like to plan my therapy in advance. So if I know somebody has a PIK3CA mutation, I may want to give an aromatase inhibitor with the CDK4/6 inhibitor and save the Faslodex to give with alpelisib, because that's the combination that's approved. So I think in patients with relapse disease after initial endocrine therapy, I personally like getting the genomic test up front.
Mm-hmm. Mm-hmm. I think you made these points well.
So I think we made those points as well too.
Yeah, we did. And so I think as we go through the guidelines, this slide summarizes the preferred regimens for HER2 negative and postmenopausal or premenopausal patients who of course have to have ovarian ablation or suppression the options are shown.
I think one more thing, Reshma, on the previous slide is I think, you know, as we have more therapies that we combine with endocrine therapy, I think it's important not to forget that we still have older endocrine therapies that we can get mileage out of in patients who have had good responses to prior endocrine therapies. So for instance, we shouldn't forget about Megace. We shouldn't forget about giving estrogen or even androgens to these patients, because you can get a lot of mileage out of these therapies in patients who have been responsive to prior endocrine therapies.
I agree. I think those are often forgotten options. We go through a couple hormonal lines and then usually we're moving on to drugs like capecitabine or other chemotherapy agents. And I've had the same experience where I've been able to get more mileage out of hormonal therapy with some of these other strategies. So as I mentioned, we have 3 different CDK4/6 inhibitors, and this is a summary slide on some of the data sets that have led to the approval of these agents. We have palbociclib, ribociclib, and abemaciclib. We don't often use ribociclib in combination with tamoxifen because of the issue with QT prolongation in that group. And this patient specifically was premenopausal, so I'll highlight some of the data with regards to premenopausal patients in the MONA-7 trial. But you see pretty consistent improvements in progression-free survival, and some data sets have also shown overall survival benefits with the incorporation of CDK4/6 inhibitors. And it's rare these days to see a patient with ER-positive, HER2-negative disease who has not seen a CDK inhibitor either in the first line or on subsequent lines of treatment. And again, this is a quick summary slide of the various data sets, not just in the first line setting, but even in the second line setting in patients that have progressed on aromatase inhibitors. And some of these trials also included chemotherapy in the metastatic setting, showing again, very consistent hazard ratios and very consistent benefits seen with all 3 of these agents. I did point out that the MONA-7 trial is the only study that was exclusively including premenopausal patients. So these were premenopausal patients that received ribociclib or placebo and ovarian suppression plus an AI or tamoxifen, and there was an improvement with the addition of ribociclib and an overall survival benefit that was noted in this premenopausal patient population. In terms of the differences among the CDK inhibitors, I think, Lisa, you were going to go through these with us.
So as far as the CDK4/6 inhibitors, they've really been beneficial to hormone-positive breast cancer. In the dosing, it's a little bit different with the ribociclib and the palbociclib. They're dosed once daily, 3 weeks on and 1 week off on schedule. And the abemaciclib is dosed continuously at twice daily. The abemaciclib, we deal with a lot of diarrhea associated with that many times, as well as there is a risk of a slightly higher increase of thromboembolic events. Although I've not seen that, I have seen the diarrhea with that, but not as much the thromboembolic. Whereas the palbociclib and the ribociclib are associated with higher rates of neutropenia. And I think an important point to bring up with that, a lot of the people who are getting these have previously been on chemotherapy where they experienced some neutropenia or else had big discussions. It's important to let them know right up front that we look at this differently than the neutropenia associated with chemotherapy, as there can be a tendency to let the blood counts be a little bit lower and know that there is no higher risk of infection in this patient population. And then also in ribociclib up front, it can cause prolonged QT cycles. And so we will test up front with the EKG at baseline at 2 weeks and 4 weeks. And I have not seen any patients that had any issue with this, and we haven't needed to follow it up after that. But there's difference in the efficacy for endocrine sensitive and endocrine insensitive patients, but there's no direct head-to-head comparisons at this time. Next slide.
So let's get back to our case again. I won't go through these details with you again, just to remind you of where we are. Here, she receives first-line treatment with an AI, ovarian suppression, and ribo, and after about 2.5 years, develops progressive disease in the bone and liver, and again undergoes a biopsy Here, the biopsy was sent for PIK3CA mutation testing, and she harbored the mutation. Elisa, I think you're slated next to go through our second-line treatment options. Oh, you're on mute.
Gosh, I keep turning it off. Sorry. So after a CDK4/6 inhibitor, it's sort of the Wild West out there. We can use a lot of different therapies. Clearly, the second-line hormonal therapy we want to use is a SERD, and fulvestrant's the only one approved. But we do know that fulvestrant in combination with another therapy may improve their prognosis. So we are currently participating at University of Miami in a national trial called the PACE trial, which randomizes patients to fulvestrant, fulvestrant plus palbociclib, or fulvestrant plus palbociclib plus avelumab checkpoint inhibitor, to look to see if second-line CDK4/6 inhibitor continues to improve prognosis, which is a question we don't know, unlike continuing Herceptin, for example, in HER2-positive patients. So this trial aims to address whether continuing the CDK4/6 inhibitor improves the prognosis. Another trial looking at the same thing, but with ribociclib as opposed to palbociclib, is the MAINTAIN trial. This does not have this checkpoint inhibitor arm, but it's fulvestrant alone versus fulvestrant with ribociclib. Next slide. And then we have the SOLAR-1 trial. So again, I think it's important that we make sure we get genomic testing on our patients so that they don't miss out on a really important therapy. So the SOLAR-1 trial randomized patients with recurrence or progression after an AI who had a PIK3CA mutation or not, to fulvestrant plus or minus alpelisib, looking at progression-free survival with secondary endpoints of overall survival. It also looked at this in the PIK3CA non-mutant subgroup. Next. And as you can see here with the primary endpoint of progression-free survival, there was a marked improvement in the patients taking alpelisib. So the median progression-free survival in the alpelisib arm was 11 months versus 5.7 months. And it was approved for this indication by the FDA in May 2019. And updates have shown an overall survival advantage at this point. So it really is an important drug for our patients, and we don't want to see them missing out on this drug. Next. So side effects of alpelisib are very difficult. It is a difficult drug. Rash being the most common side effect, which can be prophylactically treated with antihistamines. Diarrhea and hyperglycemia are also very, very common and important side effects. I have seen patients with extremely high glucoses of 500, 600 with alpelisib, and I educate my patients to call me right away if they're exceptionally thirsty, urinating a lot, and educate them about the diarrhea. So it is not the easiest of drugs, but again, it does show a marked improvement in patients' prognosis if they do have a PIK3CA mutation. Next. And this slide really shows whether this drug works in patients who have previously been treated with a CDK4/6 inhibitor. So it was a small subgroup on the SOLAR-1 trial that had a previous CDK4/6 inhibitor, but we still seem to see an improvement in progression-free survival in this subgroup. Next. And if you look at the BYLieve cohort, so the BYLieve cohort looked at patients who'd had an AI and a CDK4/6 inhibitor prior to going on fulvestrant and alpelisib, and they did see an improvement in progression-free survival in this group of patients that had previously been treated with a CDK4/6 inhibitor. So I think a good sequence of events, a sequence of therapies that we can use for our patients with metastatic disease is, first-line therapy with an AI plus a CDK4/6, and moving on to fulvestrant plus alpelisib in patients with a PIK3CA mutation.
So Lisa, as an advanced practitioner, you tend to get a lot of the calls. You're our first line when patients call and have side effects to many of these targeted treatments that have helped us combat endocrine resistance. What has your experience been with this agent? I know you're going to go through the management of rash and diarrhea, but in clinical practice, what have you seen?
A little bit of all of it, and then none at all in other patients. It's very unusual, but the key again is that collaborating with the oncologists I work with, that we will often come on in and discuss right up front. The key is not to say, call if you have any problems, period. It's talking to them up front and saying, diarrhea is very common. I'm going to give you this prescription for loperamide and that you're going to have on hand, and this is how we're going to have you use it. What is your baseline bowel movement, so we know what the baseline is? Because I had someone who had hemicolectomy before. Baseline was 4. So, in a normal person, 7 stools a day would be grade 3. And this person, if she had 6, it was more like a grade 2 to her. So, giving them the tools up front. You may have a little rash. If you notice anything, here's loratadine. Let's try that once a day, or even just topical diphenhydramine or topical steroids. And then let's just keep a conversation going about it. And if the people are close, or we can even, we've really gotten used to using telemedicine, that, you can see things and discuss things even along the way, that if they want to schedule something like that, but to really monitor them closely and let them know very well what they may see up front. The diarrhea can be very significant in some people, and as I said, little to none in others. So letting them know up front what it is, and to have the communication about it. Also very important, next slide. We want to be sure that we are checking up front that hemoglobin A1C, and what is it? I will make sure I have a fasting blood sugar up front to see where they are, as well as the hemoglobin A1C, and counsel them about limiting their sugar intake as well as their carbohydrates. Everybody has their favorite carbohydrates, whether it's rice noodles or whatever, depending on the culture. Very important to watch that. And we'll jump in much sooner than others, that if I see that the blood sugar has popped up even after 1 or 2 weeks, I will go ahead and get endocrine therapy involved. Sorry, not endocrine therapy. I'll get the endocrinologist involved to be able to work with this, so we can maintain that, because we want to know that our long-term goal is we've had another option at this point to chemotherapy, and anything we can do to maintain and get them with this for the benefit is good. One interesting thing is, it is, when you see the blood sugars go to 500, insulin is not helpful with this particular type of toxicity. So it's really important we try to control it on the front side with the glucose management.
Elisa, I think you wanted to make this point about other options for therapies that are useful in certain circumstances.
Again, yeah, I think we spoke about it briefly before, but again, let's not forget our older therapies, Megace, estrogen, androgens. I like using a lot of androgens, and also, third line treatment with exemestane plus everolimus in patients who don't have an ESR1 mutation. We can always circle back to tamoxifen, and there's lots of clinical trials looking at oral SERDs as well.
Mm-hmm. Mm-hmm. So let's get back to our case. In this case, the patient is put on fulvestrant and alpelisib and develops a rash and hyperglycemia, but is able to stay on treatment for 9 months. And at that point, she develops progressive disease in her liver, and also now develops lung metastases. At the same time, her sister is diagnosed with breast cancer, and her sister undergoes genetic testing and is found to have the BRCA2 mutation. I hope that many of us would have thought of testing her prior to this point. I think Kelly had brought it up even when we were talking about the early stage management in terms of mastectomy versus lumpectomy, and even consideration for bilateral mastectomies had we tested her earlier on. She did have a family history of breast cancer in her mom, although it was later in life, and her another family member had pancreatic cancer. So clues that this is a patient that may have been appropriate to test earlier on. And she was also young. At this point, she's finally tested and has found to have the same mutation in BRCA2. And as a reminder, I think this was brought up earlier in the discussion as well, that all metastatic patients, now that we have a very targeted treatment for patients with germline BRCA mutations, and some recent data that was even presented looking at patients that have somatic mutations in other other genes possibly responding to PARP inhibitors, although not approved in that setting. We have 2 PARP inhibitors, olaparib and talazoparib, for patients with germline mutations. We often think of testing patients that are triple negative, but there are several patients that we may be missing with ER positive, HER2 negative disease. So it's important to take a good family history and have that history updated as you see patients in follow-up for years. Many of these these treatments are generally well tolerated, have been compared against chemotherapy, and from a side effect profile seem to be easier to tolerate, and have also demonstrated improvements in efficacy in terms of median progression-free survival being longer with the PARP inhibitor. And finally, as we always remember that there are several ongoing trials. Elisa brought this up with oral SERDs, which hopefully will be of benefit. Many patients don't like the IM administration of fulvestrant. It becomes an issue, and some of these therapies have even been shown to be effective in patients who have progressed on fulvestrant. So these are trials to watch. And then the ongoing Destiny-4 trial looking at patients that are ER positive, HER2 low, meaning IHC 1+, 2+, but FISH negative, in which patients are randomized to trastuzumab deruxtecan versus investigator's choice chemotherapy. This is another study that we're very interested to see and could potentially result in a new treatment option for patients with ER positive, HER2 negative, traditionally thought to be HER2 negative disease in the future. And with that, I will ask all of you to maybe close with any last thoughts that you want to share on this case or your general strategies in the treatment of ER positive, HER2 negative disease. Elisa, you want to start?
Sure. Again, I think that we're often too quick to jump to chemotherapy in these cases. And in patients who have had a response to their first-line hormonal therapy, I think it is worthwhile pushing multiple different hormonal therapies. We know that even in patients with, primary resistance, they do respond to a first-line AI and CDK4/6 inhibitor. I think it's important to try to continue on the hormonal therapy path. It's best for their quality of life, and they often respond longest to it. And I think a visceral metastasis does not mean that they need to be on chemotherapy.
Thanks. Kelly, you want to add anything from a surgical perspective?
Yeah, I'll just say that from the very beginning, this patient is a very complex case, and it's so critical that we work together as a team to try to think about the optimal management, whether it's local regional therapy first, systemic therapy first, what type of systemic therapy. We talked about genetic testing. Some of the things that we didn't talk about were, did she have genetic testing in the beginning, and was a BRCA mutation carrier? How would we do her treatment in terms of mastectomy and reconstruction, especially with many positive nodes? She would need radiation therapy, and that's a complicated issue as well. So I think that the whole team working together from the beginning to try to map out what is going to be the best strategy for the patient, and making sure that as we employ our different therapies, whether it's systemic therapy first or surgery first, and how we map that out for the patient, getting the best long-term outcome is really critical for us to all work together.
Absolutely. Mike?
From my side, I think that the most important is to be reminded to ask the patients about use of alternative therapies. 75% of our patients are using it and not disclosing it to us. So always ask, are you using any other supplements? Are you using any other therapies? And then to have an open discussion with them, being open-minded, but also, and I hate to say it this way, judgmental about some of the therapies, so that we can better advocate for the patients to have the best survival possible.
Thank you. And Lisa, I'll close with you. Oh, you're on mute.
We're always on mute.
Okay. Hey, I think it's a reminder with hormone positive breast cancer and letting them know the destination is quality and then quantity of life. And that it's a journey that we're often going to be on for years together, but we are doing it together. And sometimes the best therapies are ones that are in the works when they're diagnosed that they may end up using, but we'll keep our eyes open and work together and work towards the best outcome in the future.
Thank you all for your participation. I hope the session has been valuable to all of you. I'd like to remind you that Total Health has $50 Uber Treats gift cards that could be yours by participating in the Engage and Win giveaway. Remember to visit the exhibit booths and engage with the industry representatives for your chance to win. After the break, we will head back to the general session where you can select between 2 lunch presentations. Thanks everyone, and I hope to see you live in Florida next year.